And so, how do we help patients with relapsed small cell lung cancer live longer and have better control of this challenging disease? We have to start with transforming the landscape of small cell lung cancer. For some patients who may not be diagnosed with small cell lung cancer, perhaps in the future we could employ lung cancer screening to help patients who might be diagnosed in a year, in 5 years, and 10 years down the line to be diagnosed earlier with earlier stages, such as limited stage or even stage one disease for small cell lung cancer, where we can provide more curative treatments with chemo, radiation, immunotherapy, and help more patients be cured of this disease ultimately overall. But for the patients who may have extensive stage or may have relapse of the disease, we have to improve our efforts to help really overcome this disease once and for all. So today I'll be speaking to you about the role of antibody-drug conjugates or ADCs in the role for treatment of relapsed small cell lung cancer. So what is an ADC? These antibody-drug conjugates are what you want to think of as a Trojan horse. It's an unassuming antibody that binds to the surface of small cell lung cancer to recognize a protein with an antibody. And so, kind of a lock and key there to recognize something that is on the surface of the cancer cells. And when it is brought in like a Trojan horse into the small cell, it has a chemotherapy payload that provides a missile to go and kill these small cell lung cancer cells ultimately once and for all. And so this unassuming antibody is ushered in, but on the backside of it has a chemotherapy payload to really kill the cancer cells after they brought in this antibody. So as mentioned, it's a biological missile. These antibodies recognize a target that provides a targeted drug delivery. It's brought into the cell. It releases the chemotherapy, as you can see here, and through these endosomes and lysosomes. The chemotherapy is then enabled to be released into the cell. It kills the cancer cell. That cancer cell dies, and it may actually kill the surrounding cells. That's called the bystander effect. It may not only kill the single cancer cell that it absorbed it, but also the ones around it. And so this is exciting because it can kill multiple cells, hopefully in one fell swoop. These cells undergo apoptosis, which is called programmed cell death, and these small cells are toast. This is what we want to see. So what are the targets? What are we recognizing on the surface of small cell? This is a widely exciting and developing area for small cell lung cancer, but some of the targets that are under clinical development are shown here, namely TROP2, B7H3, DLL3, which you remember from tarlatamab, that DLL3 target, SEZ6, and other targets that may be under investigation for small cell lung cancer. So what are these targets? These are targets of, they're called proteins. And there's genes that make these proteins. So these are SEZ6, seizure-related 6 homolog, DLL3, delta-like ligand 3, CD276, which is the gene for B7H3, and TAC-SD2, which is the tumor-associated calcium signal transducer, which is the gene for TROP2. There was a recent study presented earlier this year by Dr. Ashvin Talati and the investigators looking at these targets in patient samples and in cell lines from small cell lung cancer. What you can see is that the levels on the left are showing different levels of the RNA in these patient tumors, where we can see there's very high levels. This is a log scale, so these are very high levels of these targets in the small cell lung cancer tumors. You can see that it says 6, B7H3, DLL3, and TROP2, as outlined here, very widely and highly expressed across small cell lung cancers. They further investigated if potentially these are may correlate with what we know about small cell lung cancer with the neuroendocrine subtypes, which are ASCL1, NeuroD1, Pal2F3, and the more controversial YAP1. And what you can see is that there may be some correlation with the B7H3 and the neuroendocrine subtypes compared to the others like SEZ6. I think more to come here. We just don't have enough information. if there's any correlation of the neuroendocrine subtypes and the ADC targets for small cell lung cancer. We know that DLL3 is commonly uh, prominent with ASCL1 and the neuroendocrine-like phenotype. But again, it's not a perfect biomarker, so I think more to come, more information here to learn. They also looked at, do the levels change over time? Let's say a patient is diagnosed and then had another biopsy later in their therapy at relapse. While that's not very common practice, it does tell us about the biology of the disease and are these stable over time. And what you can see here is that in general, these are stable with the addition of chemo and immunotherapy and other agents that we have in the clinic for small cell lung cancer. So again, seeing that stability with SEZ6, B7H3, DLL3, but perhaps the TROP2 might be slightly lower with relapse may suggesting that earlier that we can target this protein, the better. Maybe a little bit later, it may not be as active as of a target as we'd like. Again, validation of this in the clinical setting is needed.